to Professor Byrne, and he's now got 7 minutes only to tell us what the UK challenge, appreciating this is an international symposium, but what are the particular challenges for us here in the UK, and indeed the opportunities, and as our current president, we would hope he has some answers for us all.
So firstly, thank you to Sanjay again for inviting me again, thanking them to present this year. I think this is a UK-based talk. I'm here in my capacity at BOMS, which is the British Obesity and Metabolic Surgery Society, but I think there are some challenges that are similar around the world and also potentially some opportunities. And the purpose of BOMS is access to safe and effective treatment for people living with severe and complex obesity across the UK. So, where are we right now with surgery? These are figures from the National Obesity Audit over the last 5 or 6 years. And our current steady state is about 4,500 procedures a year in the NHS in England per annum. In addition to that, we've got about 5,000 or 6,000 procedures a year being performed in England in the private sector. Anecdotally, that's maybe a bit less than that. 8,000 people a year, again that's dropped off a little, travelling to Turkey every year. And we have about 8,000 people on the waiting list for bariatric surgical treatment in the UK, which is interesting. That's the same when we go to Turkey. And so that is not great. So within that, this slide demonstrates that there are quite marked differences from one area to another in the UK. So at the top, we've got the North East in Cumbria, 11 per 100,000. In the ICB immediately adjacent, the numbers are 1 per 100,000. This is all easily accessible on the internet. So these tirzepatide. So NICE has issued guidance for tirzepatide, and I think this is relevant to BOMS because we are about treating people with obesity, not just with surgery. I think we need to pivot towards medical as well as surgical treatment as a professional body. And the recommendations, they're draft guidelines right now, are very helpful, very evidence-based. The problem with implementing them is that primary care will fall over on the grounds of professional clinical capacity and cost. So NHS England and the Integrated Care Boards have jointly written what is called a funding variation proposal. In essence, this is a request to implement the tirzepatide guidance over a period of time. And the number there that's of relevance is at the bottom on the left, which is 12 years. And you think, oh my goodness. But the interesting numbers are over on the right. So this, they're looking at the first cohort. This is just provisional at the moment, treating people with a BMI of over 40 with 3 or more weight-related health problems, and they're looking at 42,000 patients in the first year, which is nearly 10 times the number who are receiving surgery. Scaling that up rapidly over the following years. There's lots of complexity about how this is all paid for, but this is where the government currently is, or what's being proposed in terms of implementation. So, what's BOM's role in all of this, and what are we doing? Well, this is a diagram, I think, of all of the stakeholder professional bodies and also some of the patient-facing bodies. I bring a notice to the bottom left here, Obesity Voices Hub, and this is a group that's based out of Leeds Beckett University, with whom we are setting up a full proper PPI group who will be paid along with in parallel standard NHR rates, etc. And we have built on existing relationships with the organisations down on the left, and we've built some new relationships, for example, with the Royal College of General Practitioners. And the reason for all of this is to try and, we are the expert body for this group of people. And what we have a great opportunity to do here is to influence and support and help the NHS England. So we have a new obesity lead, Claire Hamling, who's a general practitioner, and her obesity advisor, who's just been officially appointed in the last week, is Dr. Catherine McDonough. And Catherine is a bariatric physician supporting an obesity surgery MDT. And she believes in surgeries who are really, really well placed to influence and support some difficult decisions looking forwards. Now, NHS England instructs the integrated care boards, and they have a number of legal obligations, including the health and well-being and addressing inequalities in health. And the people that we treat on the NHS are square in the middle of that group of individuals. And this is Alex Miras kindly gave me this slide. I think at an ICB level, in the medium term, we're going to have to shift and think differently about who does what in terms of obesity. So a lot of this care is going to have to be delivered in primary care. But at an ICB level, we need to network as specialist centres to support and train and teach and enable and help our primary care colleagues who will be dealing with the vast majority of medical treatments of people with obesity. And looking forwards at a big level, there is an NHS plan that will be announced, and the three priorities on the left are priorities that we should align with. And on the right, Eli Lilly have pledged a lot of money, and we can work with Eli Lilly and drug companies to create and deliver research. There is a live bar study, which is a trial of medicines versus bariatric surgery that is jointly being run between Denmark and the UK. These are some of the things that we can think about. We can influence the decisions about where GPs send people, either off beds or for surgery, thinking perhaps these criteria. What we do, this is the most important slide, and I'm sorry I've run out of time. What we need to do when we go back to our hospitals is focus on what we do and how we deliver, and making sure we get the best possible bang for the buck. We need to go from 3 or 4 patients on the list, we need to move towards 5. Some of that is nothing to do with us, it's to do with the practice of our anaesthetic colleagues, the theatre staff, but we and our industry colleagues who are out in the exhibition, J&J, Medtronic, are all over this. Please talk to them, please get them to help you change things in your hospital. So I'll finish on this slide. So I think there has been some pessimism around bariatric surgery. It's interesting, you walk around the hospital and lots of my colleagues are coming up to me saying, well, you guys are out of job. You've had a good run, Jim. You're 60, you'll be retiring next year, and I think we have only just seen the beginning with bariatric surgery. I think we've got lots of amazing opportunities, and the demand for it is not going away, and we should deliver, and thank you very much. I'm sorry for everything.